So let's continue on with our discussion of the side effects of omeprazole and indeed PPIs generally. It's not just omeprazole that has these side effects, they all have these side effects. So actually let's skip this one, we'll come back to this one last, and let's go to this one at the bottom because this is actually related to what we've already discussed. So we've discussed about how PPIs can affect the kidneys and lead to electrolyte derangements, but they can also affect the kidney's ability to excrete waste products. So remember, the main function of the kidneys, well, there's loads of functions of the kidneys. One is controlling electrolytes, but two, they excrete waste products. So there are loads of waste products produced by our cells all the time, and these are excreted by the kidneys. And if they don't excrete the waste products properly, they build up in the blood, and that's something called renal failure or uremia. And one of the side effects that can happen with PPIs is they actually reduce the kidney's function. They reduce the kidney's excretion of these waste products, and therefore they can lead to the waste products building up in the blood, and therefore can lead to a mild increase in uremia or indeed renal failure. Now, this is a temporary non-permanent reduction in renal function. So it's not that these drugs are damaging the kidneys and destroying nephrons and destroying their ability permanently to function. It's that they are temporarily reducing the efficacy of the nephrons and therefore leading to waste products building up in the blood, potentially. And this isn't a guaranteed side effect, this is a possible side effect that can occur with PPIs. So once you stop the PPI, if this has occurred and you stop the PPI, then the renal function will return to what it was previously. So the main reason that this is important to know about is if you have a patient who has very poor baseline renal function, so let's say they have disease of the kidneys, maybe they are diabetic and hypertensive, both of those conditions are not good for the kidneys. They lead to gradual degeneration of the kidneys, loss of nephrons, and permanent loss of function of the kidneys, and the kidneys often shrivel down with these conditions. So let's say they have very poor baseline renal function, and the waste products within their blood, which we can measure on blood tests, or at least we can measure certain of them, and the ones that we usually measure, I'll just write down here. So I've written down here some of the clinically used waste products that we can measure in the blood. So urea is one of them, and its normal level in a healthy person with good kidneys should be between 2.5 and 7.5 millimolar. Another one is creatinine, and its level in someone with healthy renal function should be between 50 and 120 micromolar. So if someone has permanent renal failure, chronic renal failure, also called CKD, and again I'll just write that down. So here we are, CKD stands for chronic kidney disease, and this means that their renal function is permanently reduced because of some sort of disease that has degenerated or destroyed the kidneys. So if someone has got CKD, their waste products, their urea and their creatinine are going to be higher than these top thresholds here permanently. Now, if someone has this problem, then you need to be more cautious about putting them on a PPI, because the PPI in turn might reduce the activity of their already degenerated kidneys and lead to the waste products becoming even higher in the blood, which might lead to problems for their health, because having high waste products in the blood, as you can imagine, is not good for the function of any of the organs of the body. For all of the organs of the body to function optimally, they need the waste products to be removed and to be at these normal levels within the blood. So when they're higher, every organ of the body is less healthy, and all medical conditions are made worse by worsened uremia. So you want to be more cautious about prescribing PPIs in people with CKD. The other situation where this becomes relevant is if someone's got an acute renal failure. And the other term for this is AKI, so I'll just write this down as well. So AKI here stands for acute kidney injury, and it is the new modern term for acute renal failure. So if someone is really, really dehydrated or really, really ill currently, so let's say they've got a horrific chest infection, pneumonia, when they become really ill, it reduces the function of the kidneys, or if they're really dehydrated, the kidneys might not be able to get rid of waste products adequately. In this case, the kidneys haven't been permanently damaged, they haven't degenerated, their function has just been hugely reduced temporarily. this is what we call acute renal failure, or an acute kidney injury is the modern term for it, an AKI. So again, the waste products in their blood are going to go higher. This is another situation where you would want to suspend someone's PPI. So let's say we have an elderly lady who has got really bad pneumonia. She's come in with an AKI, but she's normally on omeprazole because she's on loads of medicine. So she's on omeprazole to protect her stomach. This would be a situation where you'd want to suspend that omeprazole, because the omeprazole, even though it's not the cause of the AKI, it might be worsening the AKI because it has this effect that it reduces the kidney's activity, reduces their excretion of waste products, and that's not something that you want at the moment. That's not something you can chance at the moment. So it's a drug that we often suspend if someone has got an AKI, to try and help as much as we possibly can and do everything we can to maximise their kidneys' function. So to summarise the points that we've just made there, in someone with CKD, be cautious about prescribing PPIs. Look up the prescribing guidelines, especially if someone's got really severe CKD. So there are different stages of CKD, ranging from 1 to 5. 1 is very mild, so mild that you don't even bother diagnosing it usually. 5 is extremely severe. If someone's in CKD 5, they're on the verge of needing dialysis or a renal transplant. In that case, you really need to look up prescribing guidelines for PPI in that case. But even with less severe forms of CKD, be cautious about what effect PPIs might have on their already poor renal function. The other situation is someone has an acute kidney injury, so an acute drop of renal function due to some current medical problem that they're experiencing, such as severe sepsis. Then you would want to suspend their PPI if they're on a regular PPI, because you want to do everything you can possibly do to improve, optimize their renal function. Finally, let's come back to this one here. So I have very little to say about this final thing. So this is the final reason that you might suspend or stop someone's PPI, which is the risk that it causes an infection called C. diff, or Clostridium difficile in full. I'll write its full name out. So here we go. This is the full name, but we always refer to this as C. diff. So what is this? So this is a bacterial species that normally inhabits the colon of most individuals, but it is normally in very small numbers. So the colon has a huge number of bacteria that live on its surface. Usually, very few of those bacteria are C. diff bacteria. They're scattered amongst all the other bacterial species there, but they're very sparse. There aren't too many of them. Now, if the number of them becomes much, much higher, it causes a problem. So normally the sparse number of them doesn't cause a problem, but if the number of them becomes really, really high, then it becomes extremely dangerous, because then they start invading into the wall of the colon and can cause a really dangerous, life-threatening colitis, infection of the colon. So we call this life-threatening infection of the colon by C. diff, we call that C. diff colitis. So how does this occur? Well, the most common way this occurs is through taking antibiotics. So just like we discussed earlier, where antibiotics can cause problems with the stomach, antibiotics can also cause problems with the colonic bacteria. So different antibiotics are really bad for causing this. So some antibiotics are not bad for killing off the bacteria that live in the colon. Others are really bad. So there are certain antibiotics that you can take that will kill loads of the other species that live in the colon, but they don't kill Clostridium difficile, and then Clostridium difficile will suddenly have no competition from all the other bacteria and will be able to reproduce and hugely grow its population numbers, and then it can potentially get high enough that it leads to and starts infecting the wall of the colon and leads to C. diff colitis. So I've written down here some of the antibiotics that are terrible for causing C. difficile overgrowths. So augmentin is probably the most common one that we prescribe. We prescribe this all the time because it's so broad spectrum. You can use it to treat chest infections, you can use it to treat abdominal infections, so for instance cholecystitis or colitis caused by other bugs such as E. coli. You can also use it to treat UTIs caused by E. coli, so it's an absolutely brilliant antibiotic. But it does carry a risk of causing C. diff because it kills other colonic bugs, but it doesn't kill C. diff, so it can lead to a C. diff overgrowth. It's not too bad, however. It's what you would class as a moderate C. diff risk. The three absolutely horrific ones that are classed as having a severe C. diff risk are written here, the three terrible C's. So ciprofloxacin is one. This is an antibiotic that is occasionally used to treat mainly urinary tract infections. It's a fluoroquinolone antibiotic. One of the infections that it's in particular prescribed for is infections of the prostate, so prostatitis in men, but it can also be used to treat upper urinary tract infections such as pyelonephritis, and it would be effective in lower urinary tract infections, although we don't usually prescribe it for lower urinary tract infections. It's considered a bit too, it would be considered a bit of a sledgehammer response to a lower urinary tract infection when you could treat it with loads of other much less likely to cause C. diff antibiotics. But ciprofloxacin, UTIs generally, urinary tract infections, in particular prostatitis, because it has incredibly good penetration of the prostate. It's very good at getting into the prostate, but it is terrible for causing C. diff. Clindamycin is another antibiotic, an old antibiotic that we don't often use that much. It's used to treat skin infections and bone infections. It's very good at killing Staphylococcus, which is the common cause of skin and bone infections. But again, its big side effect is that it's very bad for causing C. diff. And often these antibiotics, both ciprofloxacin and clindamycin, would be given orally rather than intravenously. They can be given intravenously, but often they're given orally. And orally, they're even worse for causing C. diff than IV because, of course, antibiotic is then a huge amount of it will be absorbed, but some of it will end up in the lumen, stay in the lumen, and will end up in the lumen of the colon and then be directly killing the bugs in the that live on the surface of the colon. Then finally, cephalosporins. Cephalosporins are a huge group of antibiotics. Examples are cefalexin, ceftriaxone, cefuroxime, ceftazidime. Different cephalosporins, they all begin with kef. Different cephalosporins are used to treat different things. So cefalexin can be used to treat UTIs. Ceftriaxone is often used to treat meningitis. I've also used ceftriaxone to treat discitis, which is an infection in the spine. Ceftazidime is an antibiotic often used to treat pseudomonal infections. So pseudomonal exacerbations of bronchiectasis is a common infection. So some people have airways in the lungs that are far too big. They become really dilated. So of course we all have airways inside our lungs. In some people they become really dilated and huge. And this is a condition called bronchiectasis. Now the risk of this is that you can get strange bugs growing in these dilated airways because the body doesn't seem to be able to defend them as well as normal sized airways. And one of the strange bugs they can get growing there is Pseudomonas, which is kind of a green slime. And very few antibiotics treat this, but ceftazidime, a very high generation cephalosporin, is an excellent treatment for that. So cephalosporins, widespread applications, different ones used for different things, but they all carry this risk of causing C. diff because they don't kill C. diff, but they kill loads of the other colonic flora. Now, why am I even talking about this? Well, for reasons that I will not pretend to understand, PPIs also increase your risk of a C. diff overgrowth. This is usually not clinically significant if you're just on a PPI alone. So if you're taking a PPI, you can take it for years and years, and it is probably not going to cause any sort of problem. You're not going to get C. diff just from being on a PPI. However, it becomes significant when you put these people on antibiotics that carry a risk of C. diff, because when you are on one of these antibiotics and you are taking a PPI such as omeprazole, both of them together are working against you and are putting you at risk of getting C. diff overgrowth and C. diff colitis. So you are more likely to get C. diff colitis when you take one of these antibiotics if you take it with a PPI. So it is something that I would consider suspending if I was going to put people on one of these antibiotics. So if I'm prescribing Augmentin, and the person is on a PPI, I will consider stopping that PPI if possible, especially if I'm going to put someone on one of these 3 severe risk antibiotics. I will consider very seriously stopping the PPI for the duration that they're taking this antibiotic to try and prevent them from this horrific complication that can occur with antibiotics. So those are some of the major side effects then of omeprazole and PPIs generally, and those are the major reasons that I would need to suspend or permanently stop a PPI. So with that, we will end the video. Thank you for watching. I hope you've enjoyed it and I hope you've learned something.